everyone. I'm going to be actually doing video lectures for the entire GI system that we will be covering for Nursing 323 this semester and the meds. I will be starting it on Monday, but because I won't be able to be there on Tuesday, I don't know if I will be able to finish it because of your exam. So I'm going to do both, and then that way you'll have the information. All right, so here we go. Clinical manifestations, which is going to be obviously signs and symptoms of our gastrointestinal system and how it affects us so that we may be in a dysfunctional state. Abdominal pain is really hard sometimes to pinpoint because we know it can be very, very high around the stomach and where the liver is, like right underneath the sternum. And it can actually be very, very, very low on right or left side or clear down to the pubic bone. So it's definitely a symptom of a number of different disorders. It can be mechanical, inflammatory, or ischemic. So sometimes it's very hard to pinpoint. And then in talking about the different pain types, we have parietal pain, visceral, and referred. Parietal pain we know is more localized and intense than visceral pain. It originates in the abdomen. It's going to originate in the peritoneum. Visceral pain arises from a stimulus acting on an abdominal organ, and it can many times radiate to the back area. And then referred pain we know is usually visceral pain felt at some distance from a disease or affected organ. It's usually well localized and increases as the pain in the organ increases. The skin that is felt also shares a central afferent pathway with the organ experiencing the pain, wherever the skin is over the abdomen. So let's look at GI bleeding is a very big issue, whether it's upper or lower. Upper GI is usually frank. It can be frank blood, meaning a bright red, or it can be coffee ground appearance. It's usually blood that has been affected by the stomach acid somehow. It can be caused by varicose veins in the esophagus or peptic ulcers that are high, which we're going to talk about in a minute. Or it's called, there's another thing called a Mallory-Weiss tear at the esophageal gastric junction from severe retching, meaning severe vomiting. Lower GI is caused usually by bleeding from the jejunum, the ileum, the colon, or the rectum. And it can be caused by polyps, inflammatory disease, cancer, or hemorrhoids. And then here you have upper GI bleeding. We're talking about the esophagus, stomach, or duodenum. Lower from, again, I had just said that, jejunum, ileum, colon, or rectum. Hematemesis is bloody vomitus. So basically it's vomiting and there's frank blood in it, which is going to be bright red, or it can be coffee ground appearance. And when it's coffee grounds, it's black. And that is, again, affected, they think, by the stomach gastric juices. Hematochezia are bright red stools. And then melena are black, tarry, sticky, foul-smelling stools. So we can have two different types of stools looking two different ways where there's bleeding in the colon and the small and large intestine. Occult bleeding is hidden blood. And so sometimes we'll test a stool for occult bleeding because we can't see. It's not bright red, it's not black and tarry, but yet the physician may for some reason think that they are bleeding into the stool. So we'll check for what we call occult bleeding. Acute, and I bolded this because it's important, acute GI bleeding is life-threatening depending on the volume and the rate of blood loss, associated disease, age, and effectiveness of treatment. And then we have our disorders of motility, and one of the biggest one is the GERD. You hear about people talk about GERD, and you can see by the title of why we put the acronym to it, gastroesophageal reflux disease. All that means is we've got gastro's in the stomach and esophagus, that it's coming up and out of the stomach. And it's a reflux, or the expectoring, pushing up and out of chyme. And all chyme is, you'll hear that word when we talk about the gut, is acid and pepsin together, from the stomach through the lower esophageal sphincter to the esophagus. Conditions that increase abdominal pressure can contribute to GERD. Sometimes people just being pregnant because, again, pressure. It's the baby, the elevated, large robust uterus, especially towards the end, is pushing on the diaphragm and can be pushing the stomach out of the way. And then the stomach pushes the contents up and out instead of down. And then for GERD, what are the symptoms? That's manifestations. Heartburn, regurgitation of chyme. Again, it's going to be acid and pepsin. So it hurts. Acid's not supposed to be up there. Upper abdominal pain. Usually with GERD, it's within an hour of eating. And also usually with GERD, no matter what it's caused from, the condition worsens if the patient is lying down. We know that pepsin's a proteolytic enzyme, and this over time can injure unprotected cells from mucus. Another disorder of motility or movement is pyloric obstruction. And the pylorus is the beginning of the stomach, and it's blocked or narrowing of the opening between the stomach and the duodenum. The pyloric obstruction can be acquired or congenital. It can be caused by congenital defect, inflammation, or scarring, second to a gastric ulcer or a tumor. And signs and symptoms will begin epigastric, meaning high, epi, above the stomach, pain and fullness, nausea, succussion splash. And what that is, that fancy term means it's a sloshing sound when you're listening with your stethoscope. It doesn't sound like normal peristalsis, which is just running. It's a splashing sound. Let's see, where are we? Vomiting. With a prolonged obstruction, we have vomiting. It just, because it goes down, and because there's an obstruction that's not letting it go through, it comes right back up, almost like a spring. Malnutrition, obviously, if we're not getting anything in. Dehydration, same thing. We're not absorbing fluid. And extreme debilitation. Gastric distension, meaning it's getting bigger and bigger. Stimulates gastric secretion, and vomiting is a cardinal sign of an obstruction at this stage. So the gastric, it's getting bigger and bigger and bigger, and is stimulating vomiting because it can't go down because of an obstruction. Pyloric stenosis is what we call it. Can be caused by a genital defect, inflammation. Oh, I already put that in there. Okay, good. And then we can have an intestinal obstruction in ileus. And an intestinal obstruction is any condition that prevents the flow of chyme, which we know is acid and pepsin, through the intestinal lumen, or failure of the normal intestinal motility in the absence of an obstructing lesion, which would be, an obstructing lesion would be a tumor or a huge polyp or a bunch of polyps. An ileus, and we needed to show the difference here, an ileus is an obstruction of the intestines only. We have simple and functional. And simple obstruction is a mechanical blockage of a lumen by a lesion. Torsion, meaning it's turned on itself or twisted. A herniation is an outpouching where part of the intestine is just collapsed. Or a tumor. A functional obstruction is failure of the peristalsis, a failure of the motility itself, often after abdominal surgery. And this one is very common. It's called a paralytic ileus, because basically during anesthesia, we've stopped peristalsis. We don't want, with our anesthetic agent, we don't want them to have peristalsis because we don't want them to aspirate into the lung if they were to throw up. So we've kind of stopped it. And sometimes it doesn't kick back in, and they have what we call a paralytic ileus. So what we have to do is we have to put an NG tube down. Otherwise, they're just going to blow up because we know there's normal fluid in that area. Small intestinal obstruction is the most common, and a large bowel obstruction is usually associated with tumors or inflammatory disorders. An ileus, just to back up a little bit, can be caused by either a mechanical blockage, which would be, again, a lesion, a tumor, herniation, or torsion, or a functional obstruction, which is the one we most commonly see through surgery. And here's a picture of intestinal obstruction. You can see what happens, almost always causing distension, no matter what it's from. Pressure on the diaphragm, and whenever you have pressure on the diaphragm, you're going to have a diminished respiratory volume, atelectasis, pneumonia, colicky abdominal pain can lead to nausea and vomiting, diminished absorption, dehydration, loss of all water and electrolytes. It can definitely mess up the pH, whether it's alkalosis or acidosis, and again, dehydration and so forth. And you can see everything that goes on with an intestinal obstruction. It's just not good. We can have an intestinal bowel wall edema, increased capillary permeability, which we know is usually going to lead to edema somewhere, and hypovolemia, peritonitis, and fever. So now let's talk about the pathogenesis. How does this happen of peptic ulcers? Peptic ulcers let's first look at how it happens. We have defensive factors versus aggressive factors in the body. And defensive factors are going to protect us. They're going to defend. They're going to protect us physiologically from the self-digestion that goes on with an ulcer. And how do they protect us? They serve the physiological role of protecting the stomach and duodenum, again, from autodigestion. When these mucus, bicarb, blood flow, and prostaglandins are intact, ulcers are very unlikely to happen because of the protective defensive mechanisms. When they're down or low, the aggressive factors are able to cause injury. So let's look at the defensive factors real quick. Mucus. It's secreted continually by the GI mucosa, forming a barrier that protects underlying cells from the attack of acid and pepsin. Bicarb. It's secreted by epithelial cells of the stomach and the duodenum. Most bicarb remains trapped in the mucus layer, so mucus and bicarb work hand in hand, where it serves to neutralize any hydrogen ions that penetrate the mucus. Then blood flow, obviously, we need sufficient blood flow everywhere in the body, but in the GI mucosa, it's essential for maintaining that mucosal integrity. If submucosal blood flow is reduced, the resultant ischemia, which we know whenever we have a lack of blood supply, we have an ischemic condition, can lead to cell injury, thereby increasing the vulnerability to be attacked by the acid and the pepsin that's on board. And then prostaglandins, all we ever hear about prostaglandins is we want to suppress them because of inflammation and they cause pain. But in the GI tract, it's a protective mechanism. It stimulates, what do prostaglandins do in the GI tract? It stimulates secretion of mucus and bicarb, and they promote vasodilation, which helps maintain the submucosal blood flow that's going to feed the area and keep it a very nice mucus blanket in there. They provide additional protection by suppressing the secretion of gastric acid. So there you have it. Those defensive mechanisms help us tremendously. I'm going to pick back up with the aggressive factors on the next video 2 for our gastric tract disorders.